Good evening, everybody, and welcome to today's episode of Marvelous Medicine on Heart Failure. I consider it a privilege to introduce Professor J. Balachander, retired Professor Cardiology and Medical Superintendent of JIPMER Pondicherry. Dr. Balachander did his MBBS and MD Medicine from JIPMER and DM Cardiology from GP Pant Hospital, Delhi. He established the Department of Cardiology at JIPMER Pondicherry. And when he joined, we used to even run out of ECG paper. That was the status of the department. And from there, it has now become a center with a state-of-the-art cardiac cath, angiography, and cardiac electrophysiology laboratories. He started the DM cardiology course in JIPMER and also formulated the curriculum for DNB cardiology. And Dr. Balachander has over 300 publications and has written over 15 textbooks chapters. He's a very calm, collected person and extremely humble person. If you pass him on the corridor, you won't realize that he's this accomplished cardiologist. Thank you so much, Dr. Bala, for immediately accepting my request to speak on Marvelous Medicine. We hope to learn a lot from you today, sir. Joining Dr. Balachander will be Dr. B. Harapriya, also his student. She's a consultant pediatric cardiologist at MIOT International, Chennai. Harapriya did her MBBS from JIPMER Pondicherry and DNB Pediatrics from Child's Trust Hospital, Chennai. She trained in fetal echocardiography in Mediscan, Chennai, and cardiac MRI at Boston Children's Hospital. Her area of expertise is advanced cardiac imaging, including fetal echo, cardiac CT, and MRI, and also pediatric cardiac intensive care. Harapriya has created a mobile app called Smiling Heart, which can be used for early detection of congenital heart disease, and is a founder trustee of an NGO called Mending Tiny Hearts, which helps children with congenital heart disease and their families. Thank you, Harapriya, for joining today. Last but not the least is Dr. Charumati Thangavel, literally the baby of the team today. Thank you, Charu, for agreeing to join today at such short notice when Dr. Suresh Rao had some travel. We still hope that Dr. Suresh Rao may be able to log in if internet permits. Charumati is a consultant heart failure at MGM Healthcare, Chennai. She did her MBBS from Madras Medical College and residency in internal medicine, fellowship in cardiovascular disease, and fellowship in advanced heart failure and transplant cardiology from Drexel University College of Medicine, Pittsburgh. Charu has 11 publications to her credit and has presented papers in several conferences. In her previous institutions, she has been involved in both teaching and evaluation of students. Over to you, Professor Balachander.
Can I start now?
Yes, sir.
Just give me permission to share the screen. Can I share?
Yes, sir. Yes, sir.
Yeah, is it okay? Am I seeing all of you?
Yes, sir. Fine. You can see that.
No problem?
Yes, sir.
Okay, fine. Because this step is always a little nervous for me. That's why I sent the slides in advance and ask you to move the slides rather than I do it. But anyway, it works this time. So thank you so much, Vidya and Radhakrishna, for putting me into this marvelous medicine. And the topic was heart failure, but I thought the marvelous medicine has done a lot to heart failure, especially for the treatment. Now, this is a mixed audience, as I was told, from across all ages and across all specialties. So therefore, my talk will comprise of some basic concepts, evaluation, rather than the great advancements which are taking place in heart failure. So therefore, I will not touch upon the surgical aspects of ECMO or heart transplant, just a passing reference. But I will take you through something which is unique now in the current scenario and something which is going to be marvelous. So my scope of lecture is basic concepts, little bit of pathophysiology. These are little boring topics, even if you take for undergraduates. But anyway, we just go through very rapidly. A bedside evaluation, which has some interesting aspects. I won't go through too much of bedside. And of course, the diagnosis and investigation. But finally, I'll come to advances in treatment, which you would see is a great advancement. Coming to the basic concepts, you know the heart failure definition. I won't dwell on it. It's a chronic and progressive condition. The heart is unable to pump enough blood to meet the bodies. But then there are current definitions of heart failures have changed. Now you find that heart failure, as we think a patient coming with pedal edema, abdominal distension, etc., sitting upright, is not just a heart failure. It is perhaps an end stage. We have much more things to do before that, because even when we patients were referred for a LVAD, that means for a left ventricular assist device, only 25% of these patients were in advanced heart failure at rest. So all the there's a lot of inadequacy of the definition. Now comes the biomarkers, which have become mandate for the definition of heart failure. And NT-proBNP is necessary. It's an integral component of the diagnosis of heart failure, and the use of these biomarkers as the highest recommendation. Coming to the classification and definition, I won't go into this stage. There are 4 stages, which all of you know: at risk, stage A; pre-heart failure, stage B; heart failure proper, stage C; and advanced heart failure. We see the patients only in advanced heart failure, but there's a lot of things which occur. But there's something which has changed. And what has changed is our classification of heart failure, because if you take the Journal of Cardiac Failure 2021, and this I gave a talk in CSI also, why the universal definition of heart failure has changed. It's because of so many classes which we see the patient. The classic is the reduced heart ejection fraction, which we see in the clinics, where the LVEF is less than 40%. But then you have mildly reduced heart failure, which is called as HFMREF, which is in 41 to 49%. And of course, we have this huge class of patients who are always there for both medicine people and cardiologists to give a headache, and that is the heart failure with preserved ejection fraction. They are a class of people who you will find daily in your practice, even as a general practitioner. And that is more than 50%, as done by ECHO. And then you have a last subset, and that is with modern treatment, you have people who have improved ejection fraction. And that means the baseline of 40%, but there is a 10-point increase from the baseline with the second measurement more than 40%. So it was less than 40%, it has become more than 40%. Now, this is something which is going to give a lot of people trouble, and that is the hypertensive emergency and hypertensive heart disease. More than the neurological aspects, hypertensive heart disease causes heart failure, and it increases the risk by 2 to 3-fold and accounts for almost 1/2 of the cases in the US population as a population of attributable risk. So the treatment of hypertension is of paramount importance in the prevention and treatment of heart failure, and that is why so much of stress medicines are now available. A small word about high output heart failure, which is found in liver disease, in arteriovenous shunts, in some lung diseases. Thiamine deficiency, of course, is there in chronic alcoholics, anemia, thyroid diseases, and of course, myeloproliferative disorders. But the unique nature of heart failure, it is not appropriate to have a separate classification, and we do not have, although there are elevated natriuretic peptide concentrations, we do not really come across that much in our clinical practice. There are some overlapping diagnostics like acute MI, acute coronary syndrome, again, hypertensive emergencies. This condition is going to be a big problem in elderly people, and that is atrial fibrillation with rapid ventricular response. And of course, prolonged ventricular arrhythmias goes to a particular entity called tachycardiomyopathy, which I will not deal in great detail, but it is a specific entity which we see: pulmonary embolism and pericardial diseases. So that is about the overlapping conditions. So this is our basic concepts. I have reduced it to a minimum. Now I go to the pathophysiology a little bit only, because it is going to be a little boring. But anyway, you divide it into systolic heart failure and diastolic heart failure. And this is well known that coronary artery disease, arterial hypertension, valvular heart disease, arrhythmias, inflammatory diseases, and all cardiomyopathies will give rise to a systolic heart failure, whereas diastolic heart failure is a bigger subset of patients with diabetes, with hypertension, again with valvular heart disease. And one of the conditions which is now gaining a lot of prominence in cardiology is hypertrophic cardiomyopathy, which is obstructive. The incidence, I don't know why, has become 1 in 500, and every case somebody sees has something to do with hypertrophic cardiomyopathy, especially with age. Restrictive cardiomyopathy is rare, constrictive pericarditis is rare, but amyloidosis is not so rare. And if you look at it, you may be able to diagnose amyloidosis. Now, what is the lifetime risk of a 40-year-old man with development of heart failure? The most important are all these, which I have already alluded to, but the problem now will be the cardiotoxic agents. And this is the problem that as cancer treatment advances, so does cardiomyopathy. So, for example, if you take the breast cancer drug, which is superb, the HER2 receptor antagonist, they're very good for breast cancer. They cure, but they damage the heart. And these are the patients who might come in for a transplant later on. Even the children with cancer treatment may become candidates for heart failure transplantation. And this has been repeatedly seen, especially abroad. Acute heart failure, I'm not dealing in great detail, but it is a hypertensive emergency you can take in otherwise stable patients who have a stable heart failure. Of course, atrial fibrillation is one of the commonest causes of acute heart failure in adults. And especially in alcoholics, atrial fibrillation is quite common, and hence heart failure also becomes common. The traditional heart failure which we see is, of course, right-sided or left-sided. Right-sided heart failure, where you get pedal edema, but there are pathological factors which lead to cardiac dysfunction, like aortic stenosis, hypertension. And one word about aortic stenosis, this is completely on the rise, and you get more patients simply because the treatment has become simpler than before with a percutaneous aortic valve implantation. It has greatly picked up in India and in Chennai, and perhaps in other places also. So you will get patients with heart failure, and they could be candidates, unlike the surgical AVRs, they could be candidates for a percutaneous AVRs. So that's about that. And really, it is going to change the way people look at it. Now, just a small word, you know very well about the right-sided heart failures. Pure right-sided heart failure is a little rare, but COPD, pulmonary hypertension, pulmonary valve stenosis, pulmonary embolism, these are little rarer conditions, but COPD will stand out because coronary artery disease leading to right heart failure, again, is little rarer. There are some differences between this huge subset of patients called preserved ejection fraction and reduced ejection fraction. So the pathological development have been reported as inflammation, endothelial dysfunction, and cardiomyocyte hypertrophy. But preserved ejection fraction is often connected with chronic morbidities such as arterial hypertension, diabetes, obesity, renal insufficiency, pulmonary disease, liver diseases, sleep apnea, gout, and cancer. So this is preserved ejection fraction is going to occupy a large proportion of heart failure patients in your general practice. Don't forget that there are comorbidities, and this has been proved with anemia, iron deficiency, kidney failure, diabetes, and of course, frailty. And to talk about anemia in treatment, we should never forget anemia. And now today, even last week's New England Journal of Medicine has given the usefulness of ferric. Actually, it was presented in the European Society of Cardiology from 24th to 28th August. And this was the ferric carboxy maltose injections in heart failure, which has been proved intravenous ferric carboxy maltose, which has improved the quality of life. But of course, it doesn't influence the prognosis. So there are structural changes, as I know. You have hypertrophies, you have apoptosis, etc., like any other conditions. But more interesting, you have the activation of the neurohumoral systems And this is where our treatment will play a part, like angiotensin, antagonist, or endothelin, and vasopressin, etc. These structural changes will involve the ventricular hypertrophy, and this is a big problem to treat. So with this, it's a very small aspect of the pathophysiology, which I have given you, but just to come a little bit interesting bedside evaluation. Now, this is something we have forgotten, and most of the, we don't have time in the OPD or in the clinic to look at the JVP. It has become relegated to MBBS and to MD level, not even to DM level. Even DM level people do not look at the jugular venous distension, but it is a very important aspect because you can simply look at the JVP as the patient is sitting. You don't have to do anything like 45 degrees and all that. And it can be used to estimate the right atrial pressure, and it can be used to guide the therapy. Now, there was this very famous study called ESCAPE, evaluation study of congestive heart failure and pulmonary catheterization effectiveness, which has had a pre-specified secondary objective, which could be used to assess the hemodynamic patient to advanced heart failure. So we could characterize JVP into 3 groups, less than 8, 8 to 12, and more than 12. And only 2 parameters from the clinical examination. One is the orthopnea with 2 pillows, a very simple history. Are you using 2 pillows and sleeping? And the elevated JVP will give you that the PCWP is elevated. And that's enough even for the anesthetist to assess heart failure in these patients. So this ESCAPE trial gave a very useful thing. And based on this, in 2018, we had a very simple algorithm for assessment of heart failure, which could be used by anybody. One is assess for congestion, assess for low cardiac output. And how do you assess for congestion? Right-sided congestion or a left-sided congestion. If it's a right-sided congestion, look at the JVP, the leg edema and ascites, which I told you. A left-sided, you have to look at something which I'll just tell you, the hepatojugular reflex, but a 2-pillow orthopnea, and something very interesting called bendopnea, which almost all of us have, bending down causing dyspnea. That's called bendopnea, and Valsalva need not be done. A very simple test of the low cardiac output is cold and warm extremities, and cool extremities, lower extremities if it is cold, and a narrow pulse pressure. So with this pattern, you can diagnose most of the cases of elevated JVP, especially with the jugular venous distension. This is how hepatojugular reflex is done. It is just an increase of JVP by 3 centimeters with sustained abdominal compression. So even if you do transplant patient refer for transplantation, 42% of patients had a hepatojugular reflex, and most of them will have a PCWP of more than 18 millimeters. And that is a very good thing that just by pressing the abdomen, you can have the magic of evaluating the PCWP. But of course, you must have a little time and a little effort to do that. Orthopnea is important, and as I told you, it's just a 2-pillow orthopnea, but both orthopnea and JVP were associated with a PCWP of more than 30 millimeters independent. And so they formed a score which is called as orthoedema. That means orthopnea and edema, and the severity of orthopnea and edema has been proposed. And this increased orthoedema score, I won't mention the score because it's like all scores, difficult to memorize, but this was associated with morbidity and mortality. This is an interesting concept now, which is bendopnea. Now, everybody smiles when they say bendopnea, because even when we bend down to put on socks or to tie shoelaces, we do develop some edema. But then heart failure bendopnea is a very important sign which is now being considered, and it is perhaps, it should occur within 30 seconds of bending down. And there were a lot of studies which are now undergone with systolic heart failure, undergoing a right heart catheterization, and was associated with increased filling pressures, particularly in the setting of low cardiac output. So bendopnea is this: a patient sits in a chair, bends at the waist as if he's going to buckle his shoelaces, and touches his feet, and bendopnea is considered present if dyspnea occurs within 30 seconds of bending down. And I'm very sure Many of us have this symptom. It may not be related to heart failure, but it's a very interesting concept. That's why I brought, because people keep on asking, even in the exams, they ask, what is bendopnea? People have started asking. So this is what it is. The next, as I said, is perfusion. And perfusion is the most important time for a low cardiac output with narrow pulse pressure, cool extremities, and global assessment. And even bendopnea is a sign of poor perfusion. The next, a very small aspect of blood pressure, and this is called as proportional pulse pressure. A low pulse pressure, that is systolic pressure minus diastolic pressure, is the pulse pressure. But proportional pulse pressure is nothing but systolic pressure minus diastolic pressure divided by the systolic pressure. And this can be a marker of a low cardiac output. So in the ESCAPE trial, a proportional pulse pressure of less than 25% had good positive predictive value for low cardiac output. So the overall clinical assessment was associated with a cardiac index less than 2.2 liters per minute per meter square. So proportional pulse pressure is a very simple blood pressure measurement which can assess a low cardiac index. Now, when you integrate natriuretic peptides with clinical examination, you will find that the NT-proBNP is used as a biomarker, and even in the recently completed guiding evidence-based therapy, the GUIDE-IT trial, it did look as if the NT-proBNP levels could improve the diagnosis and risk stratification of patients with heart failure. Having said this, it's not absolute. There are a lot of lab-to-lab variations in the results of the NT-proBNP. So do not be surprised when one NT-proBNP comes as 3,000 and the other one, after just about 3 months, comes to 300. A lot of variation is there, but that's the problem here. But natriuretic peptides have to be included with the clinical examination. And now we come to something which is there for India. It is not so much abroad, but it is there for India. And this is the clinical frailty scale. And that's very important to know the person, especially with heart failure. They are absolutely severely frail. Whereas it said, in fact, I would venture to say that if a person is obese, then he's protected from heart failure. At least one protection is there in patients who are obese. They don't have that much of heart failure. But if a patient is frail, his heart failure is quite a bit. This is just for a little bit about children, because I think Harapriya will be able to dwell on it a little bit. But there are some congenital causes. There are inflammatory causes. There is dilated cardiomyopathies, etc. These are the heart failure in children. And I'm sure the moderators would have seen more cases. But the important thing which I would like to again stress is, look for Kawasaki's disease. It is not that infrequent. Kawasaki's disease is a cause of heart failure in children, especially less than 8 years of age. Look for it. It resembles rheumatic fever very much. Of course, there are palmoplantar scalings and lymph nodes, etc. But look for it, and you will find quite a bit of Kawasaki's disease. Now, when you come to the common signs and symptoms, I won't go into detail, they are same. But when you're staging heart failure in children, do not use the NYHA stage. Use, I'll come to it a little later, but these are the heart failure staging in children, which is called as Ross's classification. Look for a Ross's classification this is the Ross classification of heart failure. Slightly different from that of adults, but very useful in pediatric age group for children. I'm sure Harapriya will agree with me that they tend to use more of Ross rather than for NYHA classification. Now we come to something which is very unique, which is good. I'm not going to talk about big ECGs like PQRST and heart rate and all. I'm going to talk of something which has become very modern and which has transformed ECG into something which is completely different. And this is AI. AI has been incorporated, artificial intelligence, for heart failure. And in many other fields, it is there, of course, but nothing as dramatic as ECG. Many of the ECG machines will now come with the AI. Even I recently bought an automatic blood pressure instrument, It's a bit costly, but it has got AI in that. It will detect atrial fibrillation. It will tell you the blood pressure responses, systolic as well as diastolic. A small bit of AI has been introduced even in the blood pressure instrument. What is AI ECG? What is artificial intelligence ECG? It is an expansion of the use of the 12-lead ECG to identify left ventricular dysfunction. And this is very important because a large-scale trial, Eagle, has been designed to know what happens. The AI ECG has also been embedded into a stethoscope form factor. That is, if you take there is a modern stethoscope like Littmann Echo or plain Echo, which gives the ECG, Echo Duo it's called, and they have introduced AI into that to permitting, just with the embedded electrodes during a normal examination, permitting the application of artificial intelligence. And what does it do? It does to tell you that, look here, there is a problem, there is a ejection fraction may be low, especially for patients who are receiving chemotherapy, etc. So patient receives chemotherapy, use the stent. I'm not an advocate for the stent. Use the AI ECG to know whether the patient is going in for ejection fraction less as a result of the anti-chemotherapy drugs. But to date, we have received, AI has received only for rhythm distribution. And you know about the Apple Watch, which has AI and which detects atrial fibrillation. So what does it do? It goes, the traditional ECG is taken, it goes to a convolutional neural network, which has many layers, which is, of course, beyond my comprehension to see how it exactly works. But the end result is important. If the ejection fraction is more than 35, you get a pattern of ECG. If the ejection fraction is less than 35, you get another pattern of ECG. So depending upon the patient's ECG, it will predict if the LV ejection fraction is less than 35 or more than 10. So a new diagnostic power has been added to the ECG. It can identify low ejection fraction. It can identify a propensity towards atrial fibrillation, which is observed during normal sinus rhythm. It can tell you the patient has a likely chance of developing atrial fibrillation. It can detect a hypertrophic cardiomyopathy based on its LV contours, a left ventricular hypertrophy, of course. It can detect an electrolyte disturbance to some extent and warn you that there is a hyperkalemia. You don't have to learn ECG to detect hyperkalemia. The machine itself will tell you. And of course, it can also tell some of the medical comorbidity or frailty. And now the studies are ongoing to identify markers of valvular heart disease. It can tell there is a chance a patient has mitral stenosis or a mitral regurgitation or aortic stenosis or aortic regurgitation. The ECG is going to tell you that. And of course, amyloidosis. So these are the powers which have been brought to the ECG and has been given a new diagnostic power. This is an example of a man who is a 35-year-old man, and the ECG at this time, based on its pattern, has said that its ejection fraction is likely to be 18%. It is positive for low ejection fraction. There is a 76% probability of having a low ejection fraction. At that time, perhaps he was not very sure, but subsequently, he was diagnosed to have a familial dilated cardiomyopathy. So the power of the ECG as AI for heart failure is increasing. And this is, of course, normal sinus rhythm and normal heart failure. But there is a positive for low ejection fraction. 50% can be false positive. That we have to remember. It's not yet perfect. So if you have a probability of low ejection fraction, say 2005, and then the patient has a cardiac transplant, then at 2020, it could mean a rejection. So using the AI ECG itself, we can identify whether his probability of having a rejection is low or high based on ejection fraction. So that's about the AI ECG, the huge references. I have a slide on references. The next is, of course, the X-ray. The X-ray is standard, but you have a CT ratio. You have cardiomegaly, and of course, everybody talks about curly P lines. More important, most of these ECGs, the patient would have had some pacemaker, ICD, and the important thing is to look for pleural effusion and cardiomegaly, and if necessary, you can have the cephalization. So that is nothing much about that. But when you come to echocardiography, echocardiography is the basis of heart failure management and detection. It has systolic function, diastolic function. It can do a stress echo, and not to be outdone by the anesthetist, you can have lung comets. Lung ultrasound becomes mandatory in the ICU for. See, the problem is the cardiologists don't like lung echoes. But let me tell you that lung echoes are extremely useful, and especially to detect water and to detect the overload of the pulmonary circulation. It's also useful, it was very useful when we used to do subclavian puncture for pacemaker, because in fluoroscopy, you can't detect pneumothorax that well. The minute you put the lung ultrasound and there's a sliding, is not there, you know very well that there is a pneumothorax. So it's also very useful. You need not send the patient to the radiology department for X-ray. So it is useful for ejection fraction, for the mitral pattern, and what is known as myocardial contractile reserve. And these are very important things. There is a lot of potential role of echocardiography in heart failure. And there is, of course, you know that it is repeatable, it's a very low cost. But there is a slight importance in that. But before that, let's come to the basic thing. It can evaluate right atrial pressure. People, when they do echo, they forget to look at the IVC. The IVC only the anesthetist sees, because they know that there is hypovolemia or hypervolemia, etc. And the heart failure, you know, the RV is small or the RV is collapsed. You can see from the IVC. Similarly, you can look at the pulmonary artery pressures. You can look at Doppler, and you get the TR velocities. You get the right ventricular systolic pressure. So it's very useful to have this echocardiography. But more important, what is modern echocardiography? And this, without this report, we are a little bit in the dark, and we are not so much fond of ejection fraction. Many cardiologists there, I'm very sure people will agree with me that you must use this. It's called as GLS, which you see on the left side, global longitudinal strain. It is done by speckle tracking. It's a little modern machine, but it gives information, because how much the left ventricle deforms, that is the area of contraction, not the ejection fraction, which has so much of other components to it. The global longitudinal strain is a very important factor, especially post myocardial infarction in patients with heart failure. And if you have a value of, say, less than minus 15%, 12.3 is the lower limit of minus, it comes in minus, you know you are dealing with deformation, and that is a basic thing to go ahead with our guideline GD MT. We still don't go for surgery. It can also detect amyloid, it can detect hypertrophic cardiomyopathy, and it's as useful as even MRI for the delineation of ejection fraction. And of course, the Doppler is a standard report which you'll see from everybody. What is grade 1 diastolic dysfunction? There are two peaks on the right-hand side. The first peak is known as E. The second peak is known as A. The E is on the left-hand side, the E is taller than the A. And when the E becomes less than the A, simple. I'm not going into details of anything, but it tells you that there is grade 1 diastolic dysfunction. Next time you see it, it's uniformly reported in echo report, grade 1 diastolic dysfunction. It doesn't mean anything. It only means probably the ventricle is getting stiffer as people are getting older. It has some significance in diseases, but not so much as a routine, normal echocardiographic observation. When you come to computer tomography and MRI, it's a very highly now-dependent. CT and MR has become perhaps more important than even angiography in cardiology to detect many things. And again, here AI has been used, and it can improve the speed of segmentation and reconstruction data from MRI and CT. It can detect hypertrophic cardiomyopathy, it can detect LV forces, and later on, it will be of great use because MRI is radiation-free, CT is not, still you need an angiography. And of course, again, cardiac image can be used for patient selection. And the important thing is, of course, to use this AI for quality control, for detection, segmentation, shape, and motion analysis. And this, of course, has become a field in which previously cardiologists used to think that radiologists are not needed. Now radiologists are needed for every bit of cardiac work which is needed, from arrhythmias to heart diseases, to heart failure, to valvular diseases, to myocardial diseases. Name anything, it is CT and MRI, which is a very useful adjunct for the treatment. And that's about AI. These are some of the references you can take down later. And these are the beautiful references on artificial intelligence. I tried to read quite a bit, but I could not understand the, what you call, the theory behind that. But whatever it is, it has come to stay. And it is really great to have an AI ECG in the clinic. Now let us come to the most important topic. And I think we are not, we are well within time. So I have to finish by 8:30 or 8:45. But we have a few drugs.
No, sir, we have some more time. Not
Okay. So we have I'm not rushing through this because it's a very important aspect, and treatment is always fabulous. More important is the medicines which have come into the market. And we never thought that there will be so many medicines coming in. We were stuck with digoxin, we were stuck with diuretics, we were stuck with ACE inhibitors after some time, and we thought that nothing else will come. But quickly, something came very fast, and that is where from what we said, from bench to the clinical side. And first drug is sacubitril valsartan. I'll just tell you a little bit about it. The second, of course, we don't know what is ivabradine. What really? When ivabradine came, it was defined as a drug in search of a disease to treat. That's what ivabradine was. But now we find that it has some use in heart failure. This drug called vericiguat has come in a very interesting way of treating heart failure. You don't treat heart failure by myocardial always. You treat heart failure by pulmonary veins. And that is what is vericiguat is doing. This drug has not been, suddenly the FDA has not given permission, called omecamtiv mecarbil. There was a trial which did not meet, but I suppose the day is not far off when it will come back. We'll come to that. Acetazolamide is a new entry. Acetazolamide is used traditionally. We learned it only in pharmacology. And then the ophthalmologists use it every time. It's called Diamox. We also use it for mountain sickness and high altitude. And now it has come into the armamentarium for heart failure, acute heart failure. Tirzepatide is a new drug. All these drugs are available in India, with the sole exception of omecamtiv mecarbil, which is not yet released even in the US. The HeartMate 3 is a very important thing, and I'm very sure the moderator would have seen tons of this HeartMate 3, which is now one of the best left ventricular assist device. MitraClip is also important. And then we come to some of the interesting things like V-Wave intraatrial shunt devices. And we have what is known as a personalized volume management system. That's also nothing great, but it's an ultrafiltration-like system. And then you have ICDs and CRTs, of which we have done in JIPMER a huge amount. And we have a lot of experience in ICD and CRT. We started doing without knowing its true value. We thought that everybody's doing, let's do, although we started quite early. But now let us see. Subcutaneous defibrillator has come in as a standby for ICDs. And last, I will not talk about it, and this is called flow therapy, because there are so many advertisements about what is known as EECP, but we are not sure what we are there. Digoxin, of course, is standard. That I don't want to dwell much with it. Diuretics are here, but what is interesting diuretics is this method of administration. This is called a subcutaneous furosemide administration. We can try it out in critical care units, how to just put a subcutaneous intravenous furosemide, but it comes as a special solution. Ordinary furosemide, I don't think, can be given subcutaneously. It has a separate pH, and you can give this, try it out for natriuresis. Of course, aldosterone antagonists are in stay. People use spironolactone, they use eplerenone, and perhaps the side effects are gynecomastia are not there with eplerenone. Aldosterone antagonists are here to stay. And then comes the ACE inhibitors, which is the which has become the cornerstone for treatment of heart failure, recommended for all heart failure patients, receive symptoms, and improves exercise tolerance. But remember one thing about this ACE inhibitors, use in the correct dose and for the correct time. Our patients do not tolerate very high doses. If you take enalapril, the dose in which heart failure really can be treated is about 20 milligrams. That is 10 milligrams twice daily. But I don't think our patients can tolerate, or even more than that. They use lisinopril in US in large doses. So that is going to be the problem for many of the other drugs, which I'm going to be talking. Now, when you come to ARBs, this is all so many ARBs are available: valsartan, candesartan, losartan. It would request the pharma company person to come and tell you. One fellow will talk about losartan, one fellow will talk about olmesartan, one fellow talk, so people are confused what to do. But we do think that ARBs should be used to treat patients, especially who are ACE intolerant and due to intractable cough or develop angioedema. Otherwise, there are a lot of problems. Some people swear that ARBs are as good as ACE inhibitors. We are not sure about this at the moment, but we have it in our armamentarium, especially with valsartan. Beta blockers again are the standard, and you know that you have metoprolol, which is succinate, and it is an OD dose. We have carvedilol, which is again very good for the heart failure. We have bisoprolol and nebiprolol. So you know that beta blockers still have a role in the treatment of heart failure, and they form an essential. So when you have the building blocks, you have beta blockers, you have ARNI, which I'll just talk about. You have MRA, mineralocorticoid receptor antagonist. We have digoxin, we have, of course, surgery. We have imatinib. And one group of drugs, which is underutilized in our country, but has very good potency and always used in US, is the combination of hydrolysine and isosorpide dinitrate. This combination of hydrolysine and isosorpide dinitrate is particularly useful in patients who are in hemodialysis, who have chronic kidney disease, and who have LV dysfunction. It's a good drug. The tolerance is good, despite the fact that it can cause tachycardia and it can cause a little bit of hypotension. But the drug is very good. It's called isolazine. It's quite cheap. It's available in India. And this combination is not being used by many people, but it has a specific role. And then we have ICDs, CRTs, will go up the pyramid soon. Coming to this combination of sacubitril valsartan combination, and of course, this has now become standard that people use this ARNI drug or sacubitril valsartan. The cost is per day is about 100 rupees. The problem is the tolerance, and the patients are not tolerant, and so patients receive ridiculous doses like 6.25 BD or 12.5 BD. That is not the dose in which it will act. Minimum is 50 milligrams BD, and if the tolerance is less, you may have to start with 25 BD at least if you want improvement in the ejection fraction. Imatinib, as I said, was a drug. It is about 400 rupees per day, but it's a good drug that if there is a heart tachycardia, you can add it to the beta blockers. It doesn't cause any harm, doesn't cause LV dysfunction, it doesn't cause much of hypotension. And now there are finding some uses in pediatric arrhythmias. So imatinib may have more uses than we think it is. Now just see this case report, 66-year-old man who has been in the clinic for chronic heart failure. Echocardiogram showed 45%, and she had a history of hypertension, hyperlipidemia, and chronic disease. And medications were ARNI, that is sacubitril valsartan, and carvedilol, spironolactone. And she had normal jugular pressure, clear lungs, no abdominal distension. Creatinine level was a little high. Then what did we do? We have this drug which we thought was only diabetologists regime, and which has now come into us in a great way, and this is dapagliflozin. And of course, there is some risk in that, but the minute you start that, the patient, especially with renal failure, there is improved functional capacity, improved renal failure. So a little bit about dapagliflozin. This is, the trial is called Emperor. So it's called Emperor delivers his solo. And this SGLT2 inhibitors, which was so good for diabetic control, has now come into the cardiac regimen and has become a necessary improvement in our treatment. Especially the EMPA-REG outcome and other trials have shown that dapagliflozin is very useful in treatment of heart failure. Again, in May 26, 2023, we have had sotagliflozin, which was approved by sotagliflozin is a combined SGLT2 and SGLT1 receptor blocker, and it has got renal protective effects. So this is a little bit about the SGLT2 inhibitors, which block the reabsorption of sodium. They thought that because there is a hyperglycemia or there is glycosuria, they will have a problem of urinary tract infection. It is not so. It is not that much of a problem, especially in some ladies. There's some increased incidence of vaginitis, but otherwise nothing else is there. The initial trial, there were some amputations, but that's all been not proved. So sotagliflozin is slightly different because it has a combined blocker, and so this has become so the guidelines in 2022 has clearly said that the class 1 indication for the management of heart failure. And since that guideline is published, there is a new trial, which is called DELIVER trial, which was again demonstrated that dapagliflozin was similarly introduced, and that is positive. So these are the doses. We don't go into too much of detail about the dapagliflozin. All are available in India at the moment. This drug is a very strange drug. It was used for pulmonary arterial hypertension. To some extent, it was also used as a pulmonary vasodilator, but it works by pulmonary vasodilation. It's called Vericuo. These vericiguat tablets are useful in heart failure because by pulmonary vasodilation, it is found that you can treat heart failure with drugs. So vericiguat and resiaguat was used for pulmonary arterial hypertension, but vericiguat has been used for, it's a soluble guanylate cyclase stimulator. And then, of course, you have all these drugs I have shown you from 1970s to 2020s. And now we are coming to dapagliflozin and ARNI. And there are some therapeutics under study. And these are the omecamtiv mecarbil, which has not yet got the FDA approval. There are some new mineralocorticoid receptor antagonists. There are peroxidase inhibitors, and there are adenosine inhibitors, and nitric oxide donors, as usual, which can be used for heart failure. And of course, acetazolamide has come in the ADVOT trial in 2023 for acute heart failure. And finally, we come to device therapy for heart failure, and that is beautiful, devices are available, but how many of them are really effective, etc., and prevent patients from going to heart transplantation. The first is called RV septal pacing. We have been doing it for a long time. The permanent His bundle pacing, which also has now come in. It's called the conduction system pacing. Cardiac resynchronization, which has a definite role in treatment of heart failure. And multi-site pacing is also useful. ICDs are useful. IABP has got a little back because there are some other beautiful devices in place of IABP, but still has a place for patients with LV dysfunction. And then you have a huge amount of percutaneous and surgical devices. Cardiac resynchronization therapy was our favorite. We were using a lot of resynchronization therapy, and sometimes the results are dramatic, sometimes not. In fact, the first case which I did was a patient from Trichy who came absolutely grade 4, which was class 4. She came orthopnic, and then we took her. We could not cannulate the coronary sinus somehow. It was not stable. So we called the surgeon and put an epicardial lead for the cardiac synchronization and endocardial lead for the atria and ventricle. And then she became totally all right. I don't know, she still loves to follow up whether she's there or not, but still, it was a very dramatic improvement. And then you have CRTDs, which are used for treatment of heart failure. This is the classical for triple chamber pacing or cardiac resynchronization therapy. And then, of course, ICD indications are there. There are a lot of indications for ICD. And sometimes people don't even think they put ICDs without thinking also. But they are there to stay in ischemic cardiomyopathy, in dilated cardiomyopathy as a primary prevention. ICDs are important. So many trials are there which are indicative of ICD therapy. And these are the goals: prevention of life-threatening episodes of VTVF and expanding the understanding of management of sudden cardiac death. In fact, ICDs also we started using. We were the third in the country to start using ICD in next to All India Institute. And at that time, again, I was sure that we were doing it just for the sake of doing pacemaker implantation. But so many studies came which showed the effectiveness of ICD therapy. And then there are new heart failure devices and drugs to treat heart failure. The HeartMate 3 is one of the best because it has got a transmitter which is external and a device which is small and put inside the left ventricle. And then you have the SVC occlusion device, which can rest the heart for some time. And of course, now there is a great interest in cardiologists. They are rushing, whether it's Apollo or it's MGM or it is other places. Everybody thinks that they should do a mitra clip before, if they are worth the cardiology post that they have been given. And this is the HeartMate 3, which is which has a controller and a pump. And this is the mitra clip which has definitely shown promise in patients with mitral regurgitation and heart failure. You introduce percutaneously, and you can do a transcatheter mitral valve repair. It is not a bad thing to use mitra clip as even for patients who have ultimately to go for a heart transplant, because secondary mitral regurgitation, the best method to treat is not by drugs. And then there are very interesting concepts which have come. It's called as a shunt. That means if the problem in heart failure is that the left atrial pressure goes up and there is pulmonary congestion and patient feels dyspnea and other things, and everything comes because of the increase of the left atrial pressure. So you decompress the left atrium by putting a regulator, and then you put a device which is opposite of doing an ASD closure. You put a opener and use a transcatheter atrial shunt system. And of course, sometimes you can use a LA to coronary sinus. Instead of putting it to the RA, you can put it to the coronary sinus, and then you can have a good reduction of the pulmonary venous pressure. There are two systems which were tried out in 2019 with great trials. We also thought it's going to take up. It didn't take up too much. The first system is called as a optimizer smart system for cardiac contractility modulation. It's called CCM. What it does is that you put a catheter into the septal myocardium and then give a 7.5 volts high voltage current. It will not, in the absolute refractory period. So it will not cause cardiac contraction, but it will cause a good movement of the calcium inside the sarcolemmal and other fibers, and it can modulate this cardiac contractility. There were a lot of studies, 3 controlled, randomized controlled trials. Didn't show much of improvement, has not reached the endpoint for saying that this could be FDA approved, but still it's undergoing. The next system, which is also easy to use, which even the anesthetists were using, is the Barostem Neo system. It's nothing but continuous stimulation of the carotid sinus. And this continuous stimulation of the carotid sinus can give rise to autonomic regulation or dysregulation, and correct the autonomic dysregulation and give rise to a uniform contractility based on autonomic system modulation to the heart. Again, it has not yet reached the level that it can be routine, but it's a very good method of trying to treat heart failure by, you don't implant it in the brain, but you stimulate the carotid nerves so that nerves around the carotid artery and get this out. Then the intra-atrial shunt devices I've already said. These are the percutaneous devices for ventricular reconstruction. Some time back, of course, KRB is my classmate from school. He was 1 year junior and then MBBS. He was showing a lot of interest in the shaping of the heart to make it little better for KRB is K.R. Balachander for other people. So it is a very great, there are two systems, which is called as the bioventrix revival system and the Ancora system. It will bring the shape of the heart. It was for remodeling or positive remodeling, we call it. Remodeling is not always good. So it will make the LV cavity smaller. And there are other devices, as I told you, like instead of IABP, you have this aortic percutaneous hemodynamic support device, which can be used. It's a smaller device, and it has been found to be effective. This Pro Sirion is useful. And of course, you have the sensor systems in the pulmonary artery. And then lastly, you have what is known as a personalized volume management. There's nothing but ultrafiltration, but it comes with a huge amount of software which will detect how much fluid is there in acute heart failure and how much can be removed. And this personalized volume management system has been studied again from 2019. And this REPRIVE system is now being used in many centers in the US. Now, the ultimate in heart failure is transplantation, but unfortunately, the hearts are few and there are not many. Even now, I don't hear many of the traffic accidents and patients being transferred. Occasionally, it may come, but the hearts are not available mostly. But the last interesting thing is, can the end-stage heart regenerate? A lot of interest was shown for regeneration, and it showed a transendocardial autologous bone marrow transplant. But after 2003, we have not had much progress in this, simply because whatever was made was not electrically stable. And these were skeletal myoblasts transplantations, which were showing, of course, this is in vitro, and it has shown some intramyocardial cell injections, has shown some, but still stem cells are not yet available. So to summarize, heart failure is a chronic progressive disease that is generally not curable, but treatable. And most of the recent guidelines and lifestyle modifications, still there is ACE inhibitors, beta blockers, occasional digoxin, and diuretics. And there are new drugs, ARNI, ivabradine, SGLT2, vericiguat. 15% of all heart failure patients may be candidates for cardiac resynchronization therapy. And close follow-up of heart failure patients is essential, with necessary adjustments in medical management and use of LVADs, ECMO. I have not, again, talked about ECMO much, but they have added to the technical advancements. And cardiac transplantation has become available, but still donors are the problem. So exciting stem cell therapy is on the horizon. Somehow it has taken a backseat in the recent years, may come back again. It may obviate some management situations in the future. Thank you very much.
Thank you so much, sir. Harapriya, would you like to take over?
Yes, sir.
You're muted, Harapriya. You're muted.
Okay. Yeah, I'm unmuted. Am I audible?
Yes.
Okay, thank you very much.
Just 1 second, Harapriya, sir, if you could. Thank you. Yeah, you're all set.
Yes, sir. Thank you very much, sir. That was a fantastic talk, starting from the basics up to the recent advances. Absolutely. And it really took me back to the 90s when I first heard your lectures. And the fact that you have kept up so much with and you're able to talk about today's recent advance just is a testimony to your passion for the subject and your keen interest to keep up with the advances. That was fantastic. And as cardiologists of today, like how much ever we are accused of practicing transducer cardiology, we can't resist putting the probe on the patient anytime. There is always a moment when we look back at the, like as you mentioned, for the JVP or to look for a pulse, or to correlate with the numbers or listen to a small S3, listen to a short diastolic murmur. I think at the end of it, that just contributes a little bit to our whole perspective, definitely. And of course, talking about pediatric heart failure, sir did touch upon it definitely. The classification as such is different. We look into pediatric symptoms like how they have diaphoresis, increased sympathetic activity, how they have exertional dyspnea, and how they have symptoms at normal activity like play and feeding for the kids. And of course, the commonest cause of heart failure in children, what we see the commonest is of course the left to right shunts. And of course, we see a huge cohort of myocarditis, dilated cardiomyopathies. Kawasaki disease, sir did mention. In fact, there are very good pediatricians in the city who diagnose Kawasaki very promptly and ask for an echocardiogram. And there are some senior pediatricians who have a very huge series of Kawasaki with coronary involvement. And there are some of them who have been on long-term drugs as well, aspirin, clopidogrel. Incidentally, right at the COVID pandemic, there was a lot of Kawasaki-like myocarditis in children, which also present with severe heart failure and coronary involvement. And they also improved drastically with immunoglobulins. And they all did not have any residual heart failure, of course. And being in a big pediatric cardiac surgical unit, our biggest cohort of patients are those with right heart failure, the one with single ventricle physiologies. And we are seeing a lot of them going into the heart failure stage. Of course, Dr. Charumati will talk more about the transplants and the devices. But as far as my follow-up goes, my biggest challenge is to ensure compliance of drugs with these children. We also do start evaporating sacubitril, valsartan, the whole works. But for a school-going child, to ensure this kind of medical management becomes a big challenge. And of course, the cost involved in the therapy. So otherwise, that's much about as much I would like to add, sir. And thank you very much. Your talk was fantastic. Dr. Charumati, please.
Hello all, thanks for joining. Dr. Balachander sir, I think this is the first time I'm listening to your lecture. It was wonderful. I think it was a very comprehensive overview of heart failure, and it's very nice to know that you have kept abreast of all the latest advancements, and you had like literally everything, as far as like what was presented at ESC last month. So it was really, really nice and enjoyable to listen to this heart failure talk. And it was like a crash course of heart failure, I think, for everyone. It was wonderful. I totally agree in terms of medical management. What I see here, I was in the US for the last 11 years. And I think the biggest challenge that I have here is patient not tolerating the doses like you talked about. Like patients tolerate very hefty doses of heart failure medications in the US, but I noticed that our Indian population, they do not tolerate those big doses. And I'm always trying to cut back on diuretics as I add on more aldactone, spironolactone, or arnis, because then they start getting more and more dehydrated. So I think that's one thing to keep in mind, because a lot of times the diuretics are never tapered down as you're adding on more of these medications, which also have more diuretic effect, like DAPA, ARNI, spironolactone. They all have diuretic effects, so they all potentiate each other. And I think you have to remember to stop your Diator or furosemide or whatever other diuretic a patient might be on. That's one thing. And completely agree about the hydralazine and the isosorbide nitrate. We use it a lot for our African American patients in the US, because despite being on maximally tolerated doses of guideline medical therapy, they're still quite hypertensive. And it's very good to add this medication for afterload reduction. And I personally get very excited when I see a hypertensive patient with heart failure, because then I feel like I have a lot more room to add medical therapy for these patients instead of doing, LVAD or a heart transplant. So I get excited. And we do see a lot of recovery with the GDMP. So that's quite exciting too. The audience might not know I'm at MGM, so we are a big transplant and LVAD center, and HeartMate 3, like Sir talked about, is one of the options for heart failure, and that's only for patients who have refractory heart failure symptoms, despite being on the best medical therapy that they can tolerate. By tolerate, I mean they should not be hypotensive, and despite being on adequate medical therapy, if they keep continuing to require more and more diuretics, patients, if they have ICD, if they continue to have refractory arrhythmias and ICD shocks, patients with worsening renal function or liver function, cardiac cachexia. All of these patients are patients with advanced heart failure symptoms, and these patients are already on medical therapy. I would not refer somebody for transplant or an LVAD if they have not even been given a trial of medical therapy. So that is the one thing that I want to add on from my point. But sir has been very thorough, and he's actually talked about like almost everything that he possibly can. So it was great talk, sir.
Ravi Shankar, would you like to ask the question you posted on the chat board?
Sure. My question was that, you've talked about, decreased tolerance in Indian patients. So I was just wondering if there have been any simple studies that have looked at exposures in these patients, meaning simple PK/PD studies to see if for some reason with the same dose, if Indian patients have a higher exposure. Could be anything in the ADME pathway that leads to it, but are you aware of any such studies?
Yes, I'm not aware of any such studies, but I also do a remote clinic in like smaller hospitals and see just a subset of heart failure patients. But what I have personally noticed is even with small doses of GDMP, but most of these patients are on all 4 pillars of GDMP, the beta blockers, RAS inhibitors, MRAs, and SGLT2 inhibitors. I've seen plenty of myocardial recovery, especially non-ischemic cardiomyopathy patients, even with very small doses. But this would be a great research for somebody to look at the doses of medications from our Indian subset population and to see what doses been associated more with recovery or even improvement of LV function.
That is always when these drugs were introduced, like metoprolol and beta blockers, and there were some studies because in our country the DCGA recommends that we do studies on Indian patients before they are marketed, and those studies of course are very limited, and those studies use standard doses like in US. But the problem was the myocardial infarction if you take, and then you start metoprolol. Nobody starts with 100 milligrams twice daily. They start only with 25 BD, and then we are afraid to start with that. The problem is that it's not that in heart failure, you have to give the doses in the optimum dose. Otherwise, it will not have effect. Even if you take carvedilol, taking 3.125 milligrams twice daily is not enough. You have to reach at least 25 milligrams PD of carvedilol. Yes, there would be problems, but as Madam said, you can reduce diuretics. You can add a little volume, you can encourage, and then, of course, try whether you can reach the dose of that particular drug. Even our own enalapril, we are not giving it the dose, we are giving it very low doses. 2.5 milligrams PD is not the dose of enalapril to treat heart failure. It may treat hypertension, but it will not treat heart failure.
I agree with you, sir. Like to relax the fluids once they go back on more drugs. So these things, me being a very kind of community pediatric cardiologist, that is what strikes me most. When they're in the hospital, they're like strictly monitored. We give them a chart and to chart out everything, monitor the drugs, the timely drugs. Once they go back home, it's all haywire, especially for the children who go to school and all that. So that is one of my big kind of wish list where we can kind of monitor them in some kind of a remote monitoring. At least the basic parameters, their input, output, their timing of drugs, their blood pressure, the other vitals. That would be something for, at least even if it is AI powered, that'll be a huge scope for a big project for a community level management of heart failure, definitely.
I have one more question. Can I ask that?
Yeah.
And this is to Dr. Balachander. How would you make a distinction in your choice of SGLT2 inhibitors of empagliflozin, for instance, over DAPA, given that empagliflozin has been shown to reduce, MACE events, while dapagliflozin, the CVOT, did not really show any benefit? So particularly in patients with type 2 diabetes. So would that color your choice of EMPA over DAPA in the treatment of heart failure?
Yeah, given a choice, the original compound was empagliflozin, and definitely our choice would have been that had not TAPA come. But I think perhaps it's the convenience of the of the cardiologist to include DAPA and rather than impact. But definitely, as you said, the choice would be first of impact, because the first trial which came, the EMPA-REG trial, was the best trial, and the DAPA did not have that great effort. Having said that, probably other compounds are on the way, and we would be able to get the benefit of impact. But definitely, a choice would be of impact rather than a dapagliflozin.
Thank you.
So Amit Ghosh, you want to say something?
Well, thank you to Professor Balachander for having taught us in the 70s and 80s and still continuing to deliver a lecture of such a high standard. What has become clear now is that the treatment of congestive heart failure, we had stopped at diagnosis. Most of the management which we had learned was diagnosis, all the different kind of diagnosis. But the challenges which have been mentioned by our two subsequent speakers is the management and the complexity of it. It's not only a disease, but it's also a suffering, and the whole family goes through it along with the cost which is associated. So it is beyond the scope of a single doctor or a single provider to kind of manage these patients, because it's a continuous management. So it needs education time. So most of our at Mayo, we are following, we have a separate unit, and as an MGM and most of the big centers who manage congestive heart failure patients. Even cardiologists have differentiated themselves between people who manage heart failure and people who don't do other things because of the complexity. And where the internists come in is timely management, understanding the scope, and it's ever increasing diagnostic as well as therapeutic options which have come. As really, if you do the mathematical calculation as to how many decisions you're making on a patient based on the variables that you're looking at, it will come to 50 or 60 decisions, which cannot be made in 5 or 6 minutes. So gone are the days of digoxin, however effective it was. It really needs somebody of extreme talent, extreme patience, as well as a leader in managing large teams. All of these things which we have discussed, each of these diagnostic and therapeutic modalities, randomized trial, which have been described, keeping all the other variables, have required enormous resources. Peter Altea, who talks about longevity, has come up with these 4 horsemen of chronic diseases, which includes atherosclerotic heart disease, cerebrovascular disease, which is part of atherosclerotic disease, cancers, Alzheimer's, and of course, diabetes. These are the 4 which all of us are probably going to succumb to. So the whole thing is that aging is a chronic disease, apart from just cancers and heart disease. So how to tackle it? So more information would be coming rather than bits and pieces of therapy being added to these things. A workup is going even additionally, the who's genetically prone for these things, the heart disease. The interesting thing, like we are using AI all the time, and we are looking at 8 parameters. Dr. Balachander mentioned several of it. I'm a bit cautious using it because it also tells the patient's age, the EKG age compared to the patient's biological age. And I've used it when the patient is younger by his EKG age rather than his biological age, which kind of brings a laugh to the patient and they feel good. But it is clearly happening. It's also predicting, EKGs are predicting patients with cirrhosis, with amyloid and other things. So I'm doing a daily basis with EKG on our patients. These kind of informations are being brought. The biggest challenge is who's going to manage it, who's going to fund it, what kind of systems do you want? It's more than just academic discussion. It is really a tough system process. And our pediatric colleagues did mention how difficult it is for a child and a family to have 4 or 5 drugs if it's taken more than 2 times with the follow-up, how disruptive it can be for a family. So we need extreme patience and kindness when we're dealing with this patient because they need our full attention and more than sympathy or empathy. Thank you for the time.
Subhashini, would you like to ask a question now?
Hi, Dr. Balachander. I'm so grateful to you for inspiring me to become a cardiologist. I was on a cardiology elective rotation as an intern when you actually let me put in a right particular lead. That's what inspired me to become a cardiologist. So thank you very much. And that was a wonderful talk. I have a question on two specific populations. I think one of them have been answered by Dr. Harapriya about pediatric heart failure in single ventricle patient. I wear three different hats. I'm a pediatrician, I'm a pediatric cardiologist, I'm also an obesity medicine physician. So what would be your magic cocktail in somebody with obesity, diabetes, hypertension, and obesity-induced non-alcoholic steatohepatitis?
Actually, I didn't stress on the one drug, which will possibly change a little bit. And that is also available in India. It has not changed so far. It's not a fantastic drug. It is given subcutaneously. And it's an injection, maybe once a week or once in 6 months. And that goes by the name of tirzepatide. And this is very useful for obesity. Not so much for heart failure, but it is useful for obesity. And this drug is, I don't think it will be a game changer, but it will be useful in a patient who's diabetes, who's got obesity, and perhaps there is an Indian equivalent of this tirzepatide, and many people are aware, at least the cardiologists are aware. And this is very particular of a drug which is perhaps marketed by in India only. I don't know about the abroad. This goes by the name of saroglitazar. The saroglitazar is a drug which people don't use. I have used only for reducing triglycerides, but it also has an effect on diabetic control and obesity.
Thank you very much. Yes, we're very excited about tirzepatide, as you know, because we've completed phase 2 trials. We are waiting for it to go on the market. Thank you very much. That was a great talk. Thank you.
Dr. Subhashini, just to add on, semaglutide data was actually presented at ESC 2023, and they actually studied semaglutide in patients with heart failure and preserved VF and obesity. I actually sent you the link in the group chat if you want to take a look.
Yes, thank you so much. Yes, we are already using semaglutide both in American as well as Indian patients. Thank you.
Yeah.
Dr. Bala, Dr. Bagdi has a question on the chat box.
Sure.
At what lowest TF can coronary revascularization be attempted? And how are the...
Very good question. Actually, the question is that at what the lowest ejection, as I told you, that the ejection fractions can go as ridiculous as 18% or 20%, and still one could undertake. The important thing in that context is not the EF, it's how much the myocardium is viable. So you have to take a viability study by either SPECT CT or even a simple dobutamine and see whether there will be a benefit of reduction. Having said that, if you think the ejection fraction is only 20% and there are viable areas, see, the problem is that everybody sort of dumps a patient as ischemic cardiomyopathy and say that this is the ejection fraction low, less than 35%, and he has to either have an ICD. That's not true. You must see whether there are revascularization. As I told you, as you are already aware, there are stud myocardium, there are hibernating myocardium, which will recover with revascularization. So the lowest level could be 20%, could be less than 35%, and could be less than 40%. But you can do a CABG if you feel that there is a viable myocardium. And here is where the GLS will play a part. The GLS is a estimation of how much the longitudinal fiber contracts. As you know, the longitudinal fiber is the one which is really responsible for the function. And if the GLS is, as I told you, minus 12.3, it's less than minus 15, even if the ejection fraction is a little high, it poses a risk. But if it is well within 12.3 to 15, we can take up patients for CAB.
Dr. Bagdi, I hope it answers your question. Dr. Venkatachalam, you've been there right from the first minute. Would you like to say something, sir? Please unmute yourself, sir.
Good. I'm in US now, and so I should say good evening. Bala is my classmate, and I am an anesthesiologist. And I would merely say that this was such a wonderful presentation, and it touched about so many things which are really very new to us. And so I won't really have any specific question because I will fire the questions in my personal forum with him. But anyway, Bala, congratulations to you. It was a very, very inspiring talk, very informative, and we really enjoyed it. Thank you.
Thank you, sir. If anyone has any questions or comments, please put your hand up, either the electronic hand or, turn on your video and raise your hand. We'll come to you. Meanwhile, Harapriya, anything you would like to add, which you think might have?
Yeah, I would like to ask, sir, Dr. Balachander. I mean, like GLS in single ventricle in like Fontan, post-Fontan hearts are actually supposed to correlate with the risk of arrhythmias, extent of heart failure. Though I would love to do a GLS on every single ventricle patient. Honestly, I don't do it. So I would like to ask Dr. Charumati and Dr. Balachander as well, how much do you think it is useful in single ventricle physiologies? Estimating strain.
Well, I'm not too sure. Yeah, she can answer.
No, sir, go ahead. No, sir. So we use strain a lot for even our post-transplant patients before biopsy. But I don't know for single ventricle whether we would be able to get a good strain. Again, ignore my ignorance because I'm an adult cardiologist and I hardly see pediatric patients unless it's a transplant patient, like a post-transplant patient. So I don't know how feasible it would be to get a good alignment of the software with the single ventricle and obtain images. So that might be a technical challenge because even with a regular heart failure patient, it's a struggle to align the probe to pick up the movement. Only when it gets more spherical, then it gets more challenging. And with the transplanted heart, sometimes it's easy, but sometimes, based on how it is sewed in, even that can be a challenge to get strain. So I don't know with single Fontan how it is feasible, but if it is feasible, I think it's a great instrument to use.
Yeah, I think if the single ventricle is of left ventricular morphology, the system would adjust to is better.
Yes,
again,
but right ventricle might be. Yes,
it might be not be the great idea.
Yeah. So we do both RV and LV strain. So I think you might be able to use the RV strain to superimpose on the RV if the single ventricle is with a right ventricle morphology. But I think that again would be a great research to try. Yes.
Actually, before the speckle tracking came into the scope, you were doing a very simple method, what is known as sphericity index. So you just take the longitudinal and the transverse, and you know that the heart is an ellipsoid, pronate ellipsoid. Mm-hmm. Then in heart failure, it becomes a sphere. So that much of remodeling, if you can achieve with CRT, we were doing mainly for CRT and sphericity index, we did have some publication on that. Okay. So that's a simple test. I don't know about single ventricle, whether we can use or not, but this is a sphericity index is a very simple test for detection of LV dysfunction.
Right, Radhakrishna, you want to say something?
Yeah, within the first time I saw a three-headed monster of a Littman was Dr. Balachander, because as an MBBS student and as a house surgeon, I used to wonder what this equipment is and what does it do. Anyway, the lecture is a wonderful lecture, especially hearing from Dr. Balachander for so many years. And then one thing as a non-cardiologist, a non-physician, I've learned is this bendopnea. I tried bending a couple of times and I found I'm not dyspneic. I was very happy about it. And actually, this lecture should be followed up by a cardiac transplant by Dr. Bala, and I think that will complete the whole story because, this seems to be a very interesting subject. And, as many commented, I could understand most of it actually. That's the way Dr. Bala teaches cardiology, and it is a wonderful lecture. I really enjoyed it. Thank you so much.
Actually, now we have the Littman Echo, which is not 300 monster. It is a single head or a two head, but it connects to your Bluetooth by Bluetooth to your cell phone, and it will give you a graphic recording of the phono. So the next is the Echo Duo, which gives ECG and phono. It's not very expensive, it's only about 30,000 rupees maximum. Gives a lot of information with incorporated AI. And if you look at the advertisement, we are not able to get that images which is shown in the advertisement, but it gives us a good method to teach undergraduates also. And in fact, only day before yesterday, I was conducting a session at the Satyasai Institute at Whitefield at Bangalore. And the person was talking about multiple murmurs. And he was having an echo step, a Littman. I said, why didn't you record all this and present it rather than tell why? So it will be there.
You had mentioned a AI-linked blood pressure machine, sir. Which one is that?
No, this is a standard. It's not Omron. It is an Italian make. The name is what is it? I have it here with me. I'll just. So it has an AI incorporated onto that. It's about 13,000 rupees, unlike the other machines which are cheaper. And it will tell you atrial fibrillation is there or not. It will tell you the systolic. Right from the time you wind the cuff, it will tell you whether the cuff is proper or not. So like that, it will tell you.
That sounds interesting, sir. Thank you. Thank you so much for your lecture.
Sir, so do you, 3 to 5 minute recap of your whole talk meant for non-cardiologists?
You want me to just talk about that?
Yes, sir. 3 to 5 minutes recap of everything for
Well,
non-cardiologists.
For non-cardiologists.
Yeah,
Okay.
your question sounds like ChatGPT. Can you?
No, it's a very good thing that you asked me to summarize. See, the important thing in heart failure, as for the non-cardiologist, is that that's where everything starts. If you take a general physician, if you take an MBBS student, and if you take that, it's important that they should not forget the clinical aspects which I just outlined. Simple tests. You don't have to do anything great. Feel the extremities, listen to the patient for symptoms, and see if there is congestion or if there is low perfusion. And that will alert the non-cardiologist to, except when there is a high output heart failure, about the perfusion, about congestion. So that is the first thing which is important. Do not just see the patient and refer straight for echocardiography. That is not a very good thing to do. You look at the simple signs like somebody said even S3 may be difficult for the non-cardiologist to assess. But you can see the JVP. Just sit, see the JVP is seen above, you know that. So that is one thing. That is a clinical aspect. Looking at this whole group of papers, that is where the non-cardiologist will have a role to play. And that is in patients of diabetes, in patients of hypertension, that is heart failure with preserved ejection fraction. That comes much later after the echo. But what is important is elderly patient, especially elderly females, hypertension for a long time, coming with a dyspnea. That is something to do with the diastolic dysfunction. Look at it. You don't have to worry about diastolic dysfunction. That the echo person will tell you. But important thing there is that lady is presenting not with low output. She's doing all the work at home. She's got a stable output, but the diastolic pressures, that is the left atrial pressures are high. So she has dyspnea. She may have orthopnea. She may even have a paroxysmal nocturnal dyspnea, those standard teachings which we give. That's an important thing. Having done that, come to the treatment, simple treatment. Always the diuretics are to be used before anything else. Or investigations, I forgot, investigations, simple ECG, a chest X-ray for cardiomegaly. That's enough. If you don't have to, if you have a cardio CT ratio, that's enough. Don't have to look at all the cephalization, etc. And then you come to the most important thing nowadays is the natriuretic peptides. Do not forget NT-proBNP, because not only will it give you a state of the heart, but it will also distinguish between a cardiac failure or a cardiac dyspnea and a other dyspnea. So if you have a problem to say this dyspnea is cardiac or non-cardiac, do an NT-proBNP. It may help you to diagnose. That's an important thing to remember. In hypertensive patients, there's always a question asked by many people. If you see a hypertensive patient who's in pulmonary edema in the casualty, how do you know that this patient has had a pulmonary edema due to high blood pressure? That is, a high blood pressure has precipitated pulmonary edema, or it is the pulmonary edema which has produced the hypertension. How do you know that? The examination is fundus. If you see fundus grade 3 changes, it means it is definitely hypertension. So such simple tests are very useful for the non-cardiologists. You don't have to rush. Of course, echo can be done and matter setting. And coming to the treatment, always, as I told you, simple drugs are available at your place, and the pharma representatives who are now not banned by the NMC will be visiting and telling you. We do get a lot of information. It's wrong to think that they come just to promote their drugs. Many drugs which were introduced olden times, we have learned from the, before we go to the books, are learned from the pharma people.
Thank you, sir. One of the things that struck me as an anesthesiologist when Charu mentioned about intolerance to diuretics and says that in the perioperative period, we really struggle with these patients who are who are well controlled and functionally they have come out of heart failure. They're doing well with all these drugs, and then we are forced to, either struggle with hypotension perioperatively, or withdraw some medications and take the risk of getting into trouble. So I mean, next week I have a patient who's got grade 3 to 4 diastolic dysfunction, which we rarely see, because most of the time the echo will say grade 1 diastolic dysfunction and also pulmonary artery hypertension. So he's for a laparoscopic cholecystectomy and hernia repair. So in such situations, how to decide who should get diuretic up to the end and who can tolerate before that? I mean,
actually, when you the anesthesia and the reaction of the patient on the table and post-operative are totally different from that, you see, because a lot depends on volume. And the volume assessment, if you can do quickly, is the most important. Once the volume is good, you can give diuretics, no harm. And the simple test of the volume, you yourself know as an anesthetist, that you just put an echo probe into the IVC and see the IVC diameter, and you can say. Similarly, you can't do it when the field of vision is, I mean, you can do a lung ultrasound. And I am a strong favorite of not anesthesia, but lung ultrasound has got a definite role to play. And the more you do, the more the anesthesiologist is quite adept to see the ultrasound. In fact, they do all the calculations of fluid based on the comet signs and other signs of the lung ultrasounds. It's we used to laugh at the anesthesia, but then both the pulmonologists and anesthesia have established the use of. So if the patient has a good volume and his volume is normal and the RV looks all right, it's filled, then there's no harm in giving diuretics. But if there is the RV collapse, no harm in rushing fluids, because you have things under your control in the operating room and even in the post-operative ward. So you can give volume, you can give diuretics, and perhaps, of course, you always give drugs like, for hypotension, phenylephrine and other drugs, they keep giving. Now, having said all this, one of the drugs which ensures cardiovascular stability, and this was a study which we did some time back, but we couldn't complete it, is ivabradine. if there is any problem, instead of using beta blockers, if the heart rate is faster, use evaporated, because that will ensure that they don't go into hypotension post-op.
Thank you, sir. If there are no other questions, I'd like to thank all three of you, especially Charu for chipping in at very short notice, and Professor Balachander for agreeing so fast. I mean, I just requested and he almost immediately answered yes, and he has taken so much pains, made several drafts, and I wanted to ask you, sir, if somebody wants your slide deck, is it okay to share it?
Perfect. Okay, share. No problem.
Thank you. So we'll meet again next week with another episode of Marvelous Medicine. And Radhakrishna, I have noted that we should get we should have a session on cardiac transplant sometime soon. So I'll approach Dr. KRB to find out when he's free.
If you can get KRB, it will be fabulous, because we can't get him for anything else.
No, I'll make sure to pass it on to Dr. Bala, and I'll tell him everybody really wants you to talk about transplant.
Because I have been with him from Delhi times, no, in the same colony, school, and he's the same when he was in school and when he's now.
Yes. Yeah. Thank you, Vidya ma'am, for having me. It was actually an honor to listen to him talk. I work with the other Dr. Bala, and I think now I've gotten a complete Dr. Bala experience from him. So thank you.
Their birds are the same feather.
Thank you very much, madam. Thank you very
thanks.
much for having me, sir. It was great. It's a real privilege to be here in this meeting, definitely.
So say that you know that she was saying that what are we going to do with small things? I said no, small things are big important. Yeah. So,
no, I mentioned that I am a very small person in front of very big legends. So she said I could represent the small people. So which I am very happy to.
No, but this is the age of youngsters, you know.
No, Dr. Harapriya, I felt the same way. But I only said yes because Dr. Suresh Rao asked me, and I was like, I adore him. So it's like, absolutely, sir, anything for you. But honestly, it's been a privilege to actually be a part of this talk. Thank you.
Yeah. So he kind of took the wind off your sails by talking about anything that you might have talked about as recent advance. So sorry about that. Good night, everybody, and hope to see many of you again next week on another episode of Marvelous Medicine. Good night.
Thank you. Good night.
Thank you. Thank you. Bye-bye. Yeah.